Welcome, welcome, welcome. I think with that, we're going to try to get us started. Welcome. You are here at the ETI and Mental Health Symposium. We're going to talk about current lay of the land and new horizons. Good afternoon. We're delighted that you're all here. I'm Dr. Frida Liu from Seattle Children's Hospital, CF Center, and I'm an associate professor at the University of Washington School of Medicine. I'm joined by my symposium co-chair, Dr. David Fideli, who's a senior scientist at Nemours Children's Health in Jacksonville, Florida. And we're both pediatric psychologists and members of the CFF's Prioritizing Research in Mental Health Working Group, also known as PRIME, and I'll tell you a little more about that group in a little bit. But this session is an incredible team effort in collaboration with PRIME and the CF Foundation's Mental Health Advisory Committee, also known as MHAC. And you may already be familiar with MHAC, which is the group that's bringing us, or continues to bring us, ongoing support for the implementation of mental health screening and care guidelines and mental health peer consultation groups, among other incredibly critical supports for CF mental health care. And you might not be as familiar with our new group, PRIME, because we've only been together for just over a year. I'm looking at my colleagues to check our timeline. So PRIME stands for Prioritizing Research in Mental Health, and our mission is to advance our knowledge of mental health conditions in the CF population throughout the lifespan and promote clinical and translational research that will promote the understanding, prevention, diagnosis, and treatment of mental health concerns in CF. And so we're delighted to be here. Here are our disclosures for David and myself. We are both funded by the Cystic Fibrosis Foundation for research grant support, travel support, and honorariums. And we have an ambitious agenda today, but before I get to the agenda, I just want to cover a couple of logistics. We will invite our speakers up here. We have an incredible panel for you. And after each talk, we will have just a brief Q&A for about a couple of minutes to cover maybe just one or two questions. And then at the end, we'll bring up our full panel for a longer Q&A. Please use the app if you can to bring up questions, or you can come up to the mic here. And I am hoping that folks in our overflow space can use the app and we'll still be able to get the questions answered. You can also upvote questions in the app, so that way we can consolidate some of the questions, but we will monitor and do our best to facilitate a lively discussion because we're really excited to get into it. All right. So with that, quick overview here. So on our agenda today, we actually have 5 talks by 6 wonderful presenters who are going to share with you the work and studies across the translational science spectrum, including a review of the latest findings on the association between ETI use and mental and behavioral health and/or neurocognitive symptoms, studies that aim to better understand potential mental and behavioral health side effects and other sequelae of ETI use with both pediatric and adult populations, a discussion of strategies to manage such side effects and related concerns, and finally, a looking ahead for future directions. And with that, I'm going to bring up our first presenter, Dr. CJ Bathgate. Oh, come on, CJ. CJ is an associate professor of medicine and clinical health psychologist at the Adult Center, CF Center at National Jewish Health in Denver, Colorado. And Dr. Bathgate is the vice chair of our PRIME working group.
Hello, everyone. I'm really excited to chat with you all today about the evolving science of ETI and mental health. And being a part of the PRIME group has really given me a chance to connect with researchers from various fields, bench scientists, clinical pharmacologists, GI doctors, and when our group dove into the literature on ETI and mental health, we came across unique case studies and case series accounts of individuals that had started ETI, which I'm going to start with. And then we're going to dive into some newer areas like preclinical science. We're going to talk about some pharmacokinetics and pharmacodynamics and the gut-brain axis. And then we're going to end with some of the latest mood and neurocognitive findings. So with that in mind, my goal today is to share some information with you that you might not even know that you've been missing. and to present it in a way that helps you connect with things that are not always top of mind for psychosocial providers. And so as a quick disclaimer, before we start, some of these topics are areas that I don't normally present on, and I've really relied on my Prime colleagues and my collaborations to be able to help educate me so I can educate you all on some of the latest literature. So for today, you can think of me as your friendly messenger and psychosocial translator of some of these really unique scientific ideas. So let's start with some area that is part of my wheelhouse, and this is case series and reports of unique experiences here. So these are some articles that I think are crucial to start understanding why we've started seeing some of these symptoms and why we felt this snowball effect happening, because these authors have put it into writing. So starting with the Tyndall article, they had one patient that reported worsening depression, anxiety, and sleep paralysis. Hio's group had 6 patients report mental fogginess, memory issues, word finding difficulty, and feeling less alert within the first 3 months of ETI initiation. The Lyman group documented one patient who overdosed on their ETI medication and downstream effects from that. Spolatini and colleagues had 19 patients reporting the symptoms listed here, as well as trouble with concentrating and attention. Ibrahim's group reported on 10 patients with symptoms listed here, as well as irritability. Baroud's group highlighted 16 patients with new or worsening unexpected neuropsychiatric symptoms, including those previously listed, as well as hypomania and fatigue. And then across the Arslan and McKinsey articles, there were 4 cases of suicidal ideation and self-harm, 3 suicide attempts, and an additional case of paranoid delusions. And I will say, so coming from National Jewish Health, we have a very large center. I think our census was up to 600 this year. And I can say from conversations with my patients, I have seen every single one of these, with the exception of ETI overdose, happen in our center. So taken together, it begs the question, what could be causing this? And we can all agree that ETI has had significant positive effects on the majority of individuals starting the drug, and that improvements in health have downstream positive and potentially negative effects on one's mental health and self-concept. But the evolving science of ETI is hypothesizing other mechanisms of action. So we're going to start with some preclinical science. And preclinical science is research that occurs before human clinical trials, such as lab research and animal studies. So as a quick CF 101, the CFTR protein functions as a sodium chloride channel found in the lungs, gut, and pancreas, as well as some other areas that we're going to talk about. And so when the CFTR functioning is restored and the sodium chloride channels work more efficiently, as is the case with modulator medications like ETI, it can have beneficial effects on the body, right? Less mucus production, improved digestion, and better absorption of nutrients. However, research is also emerging that CFTR protein is present in the brain, in the regions that are associated with maintaining homeostasis, memory, mood, and cognition. And so even though we know that CFTR is present in the brain, the exact functioning and distribution of CFTR across these different brain regions are still being studied. And although there isn't a ton of preclinical data on the overall effects of ETI and mental health, there have been some studies examining ETI's main drug components and its metabolites. So when elexacaftor, tezacaftor, and ivacaftor enter the body, these drugs begin their primary function to act on the CFTR protein and the sodium chloride channels. And as the liver processes the drug, enzymes break it down into smaller compounds, and these compounds are known as metabolites. And metabolites can have a number of varying effects on the body that might be different from the parent drug. So in one study involving mice, ivacaftor appeared to reduce anxious and depressive behaviors. And through the use of binding assays, which you can essentially think of as a matchmaking process. So what they do is they have these binding assays and they see how a drug might click with other areas. And when they used these assays, it revealed that ivacaftor interacted with some receptors that you guys might be familiar with: serotonin receptors and transmitters, dopamine transmitters, and opioid receptors. Tezacaftor and lumacaftor were also found to bind to other sites, including histamine 1, alpha-1b adrenergic sites, and peripheral benzodiazepine receptors. And so all of these that I've just mentioned, these are referred to as off-target sites because the drug was not originally designed to target them, but because of the similarity in the structure between the drug and other molecules in the body, it's really allowed it to bind to these sites, which then can potentially influence mood and cognition. Now, as for elexacaftor, the only neurobehavioral information that we have comes from the Kaftrio safety publication, which noted that there were adverse outcomes in a single female rat that received exceptionally high doses of elexacaftor. So given the knowledge that these parent drugs and metabolites are binding to off-target sites that are involved in mood and cognition, as well as the potential for increased absorption in the body, since the parent drugs are improving that CFTR functioning, it's very plausible that these might be reasons that we're seeing some of these side effects in patients, especially since the actual dose that's being absorbed into the body and the rate that the body is actually metabolizing it might differ across individuals. And so this context naturally leads us into a discussion about the next area of interest, pharmacokinetics and pharmacodynamics. So pharmacokinetics, often referred to as PK, is really the study of how the body absorbs, distributes, metabolizes, and excretes a drug. Now, pharmacodynamics, or PD, evaluates what is the drug's effect on the body. So is the drug doing what it intended to do, and if the drug is causing adverse events, which we call toxicity. So there's not been a ton of research published on PK levels, but just browsing through the NACFC app and looking at posters, if you guys go into the pharmacology tab, you're going to start to see a lot of this evolving. So this is an area that we definitely need to keep our eye on. And so I think that's going to give us some more insight onto what's going on. And what my curiosity is surrounds the actual drug concentration in the body, right? The pulmonologists are starting everyone on the same recommended dose, but it really remains unclear if there are different concentrations present in the bloodstream based on individual differences. And we have yet to discover if there's a correlation between different PK levels and drug toxicity. So this figure, lent to me by my prime colleague, Emma Tillman, who's here, illustrates that the parent drugs at the top, elexacaftor, tezacaftor, and ivacaftor, along with their metabolites, which are the different shaded boxes below it, it actually shows here that each has different pharmacological potency. And so without getting too technical, I'd like you to focus on the shading, and I think that's something we can all do. So that indicates that relative potency that each metabolite has compared to its parent drug. So darker shades, like the one that you see below elexacaftor, show greater activity, where lighter shades show less activity. So one hypothesis could be that certain metabolites, especially the ones with stronger potency, might be triggering side effects based on where they're binding into the body when we talked about those off-target sites. And we don't currently fully understand whether individual differences in metabolism affect the concentration of ETI, parent drugs, and the metabolites, and there hasn't been a clear correlation yet in the published literature between metabolite concentrations and adverse events specifically related to ETI. However, later in the symposium, Dr. Georgiopoulos is going to be discussing some exciting new research developments related to PK levels and PD, as well as some other developments that we're working on for a prospective study that's related to the new modulator that may be coming out as early as Q1 next year. So she's going to talk more about that. So shifting gears, we're going to talk about the gut-brain axis. And I'm not gonna lie, I feel like the gut is having a moment. The more I dive into this literature, the more I'm like, oh my gosh, like why aren't we talking about the gut more? So let's start, like, what is the gut-brain axis, you may ask, because that was certainly question number one for me. So the gut-brain axis is a two-way communication system linking the gastrointestinal tract to the brain. And when we think about the gut microbiome, it refers to all the different microorganisms, right? We're talking bacteria, viruses, fungi, and other microbes that live inside of the digestive tract and how they interact with the body. So on the left, when we think about a healthy gut microbiome, that supports digestion, right? Vitamin synthesis, our immune system. However, in CF, when we kind of think about what's on the right, we know that people with CF often have altered gut microbiomes due to malabsorption and antibiotic use. So if anybody's ever taken antibiotics in here, you know that it wipes out the bad and the good bacteria in the body. And so this altered microbiome can lead to nutrient deficiencies and a weakened barrier between the gut cells. And so this is something that we call leaky gut. And what that is where certain toxins or drugs that might normally stay in the gut are getting back out into the bloodstream. We might also see immune changes, mental health changes, and other related health problems. And so when I was digging around about what's going on with the gut and mental health, two key characters have entered the chat for me. So number one, serotonin, and number two, zonulin. Okay, serotonin, this is a fun fact that I didn't know. So the first part I did, the second part I didn't. So serotonin, it's a neurotransmitter. It regulates mood, it regulates cognitive functions, appetite, and gut activity. Now, what you might not know is we often associate serotonin with the brain, right? 90 to 95% of the body's total serotonin, though, is actually produced in the GI tract. What? Okay, so as we discussed earlier about parent drugs and metabolites and off-target binding sites, it's possible that when ETI is getting broken down and passing through the gut, that it's doing something in there to change serotonin levels. Zonulin, okay, never heard of this until I read a paper on it and put together this presentation. Zonulin's a protein. And zonulin regulates the permeability of the intestinal barrier. So it really helps to maintain those tight junctions between gut cells. And these junctions are essential for creating a selective barrier that keeps harmful substances from entering the bloodstream. And so when zonulin levels are elevated, it can allow toxins and other unwanted substances to leak into the bloodstream, as well as the blood-brain barrier, which can potentially trigger inflammation and mental health changes. And we know from the literature, there is a huge link between inflammation and depression and anxiety. In fact, elevated zonulin's been associated with OCD, bipolar, ADHD, and major depressive disorder. So if you think back to that slide that I presented, all those different symptoms that were coming out in the case series reports, sounds very familiar. Again, hypotheses. So an emerging area of research that we're interested in, and a lot of the GI docs are interested in, is exploring the role of inflammation, particularly in the gut, and how it might be linked to changes in mental health. So as we shift to the newest mood and neurocognitive findings, I want to emphasize that there's only a few published pediatric studies examining the impact of ETI and mood. But we're seeing more, obviously, at this conference. And we're in for a treat today because we have some of my colleagues that are going to be presenting on their results from the ETI study, which is in a pediatric sample. So, however, a recently published paper in a pediatric study that I can highlight is the modal CF study, and this was published earlier in the Lancet this year. So in this French sample, there were 197 children between the ages of 2 and 5 that underwent evaluations at baseline before they started ETI and during 1 and 3 month follow-up visits, and what they found was striking. They found that almost half of their sample reported sudden behavioral changes within 1 month of initiating ETI. And these behaviors were thought to be linked to ETI because of not only the timing, right? The behavior started when the kids started ETI, but when they interviewed the parents did not have any alternative explanation for why this behavior might be happening. Furthermore, when they looked at the kids that had behavioral changes, 85% of those kids had no previously documented behavioral or sleep issues. So these are new instances for these children. Among the sample, half reported sleep changes. This looked like trouble falling asleep, frequent nighttime awakenings, nightmares. 1/3 reported ADHD, and there were also reports of irritability, abnormal sadness for the child, and suicidal ideation. In a different study that focused on adolescents and adults, Graziano and colleagues had a sample of 92 people reporting on symptoms before and after ETI. And at the 1-month mark, they found that 15% of their sample reported memory problems, 12% had brain fog, and 10% had concentration issues. And what's more alarming was when they followed up with them at the 6-month follow-up, the levels remained stable. So it doesn't appear to be a blip that people are getting used to or getting over quickly. So I completely own and recognize that this talk may leave us with more questions than answers. But we've got a lot of really smart people in the room, and if any of this stuff sounds exciting to you, jump on this. Help us figure out what is going on or what might not be going on, right? We don't know. In terms of where we go from here, I definitely think we need more mechanistic studies, both in preclinical and human subject studies, to explore the link between modulators and mental health, as well as looking at that inflammation in the gut and the brain, potentially. We also should be examining PK levels, which it sounds like a lot of researchers are on that right now. So I'm excited to dive into that literature and look at the posters while I'm here and see how that might relate to potentially new or worsening mental health or neurocognitive issues. Second, we need to hone in on the subpopulation of people who are experiencing mental health and neurocognitive symptoms. So a lot of the research in the past 2 years has focused on the overall population of people taking ETI, finding no significant changes in mood. That makes sense, though, because when we look at averages from the entire population of people that are taking ETI, it may overlook or mask the specific side effects that are being reported in what seems to be about 10 to 20% of our population. Lastly, we need innovative study designs. Approaches like neuropsychological testing, not just asking, are you having brain fog? I want to see some objective neuropsychological data on this. Neuroimaging, collecting biospecimens to analyze inflammatory markers, and using both prospective and observational designs, all of which are going to be crucial for gaining a deeper understanding about these links. So I want to give a huge thank you to the Prime team for broadening my perspective on research related to ETI and mental health, especially in areas that I hadn't previously considered or understood. And it really highlights the needs for across multiple disciplines. We can get these answers. We just need to work together. Thank you. Thanks.
Okay, thank you, Dr. Bathgate. And also thank you to Stephanie and Deborah for submitting questions. You're my favorite attendees so far, so thank you for doing that. CJ, first question, can zonulin levels be checked with regular blood draws, or do you have an idea on how it's checked?
You know what? I love that question because I need to figure that out too. And I think my GI doctor might be in here if he made it. But if anybody knows, if there's a physician in here that wants to just like shout out the answer just for crowdsourcing, or if anybody knows, say what? Yes, blood. Okay, answer is blood. Blood for 500. You got it.
And it's getting rich. Okay, and then the other question, just more, I think, broad. We can circle back to this one at the end of the session when everyone's presented, but any preliminary ideas on what CF centers can do to prepare to handle anticipated mental health challenges when VTD is approved, given everything we've presented today so far?
Okay, so first, what is VTD? Is probably what some of you are like, wait, what's that? It stands for vanzacaftor, tezacaftor, ivacaftor. And this was the press release that came out by Vertex that they just did a bunch of phase 2 clinical trials, and it's now being reviewed by the FDA. And I think the FDA is set to give their response at the beginning of January. And so, great question. What should we do? And I want to hold that thought because my colleagues are actually going to be talking about that, and I really don't want to steal your thunder. So I will leave that for Dr. Georgiopoulos, but we will be circling back to that question, whoever asked that.
So
I think one more question. Yeah.
not that I want to give everybody something more to think about, but
Please do.
We now know that both elexacaftor and vanzacaftor, so the VX-121s come out, they both directly influence action potential firing in hippocampal and cortical neurons because of their effects on other types of channels, not CFTR.
Right.
So it's just something to think about moving forward, that we know there are direct effects on action potentials now.
Right, and the hippocampus is involved in memory, and so when we're thinking about brain fog, concentration difficulties, I think that is a really great point. So definitely come talk to us afterwards and we can chat more about it and pick your brain.
All right, and next up we have two presenters, and I'm going to introduce both of them at the same time. We have Drs. Robin Everhart and Emily Muther. And Dr. Everhart is a professor of psychology at Virginia Commonwealth University and a pediatric psychologist. She is also a member of PRIME. And Dr. Muther is an associate professor of psychiatry and pediatrics at the University of Colorado School of Medicine and a pediatric psychologist in the Cystic Fibrosis Center at the Children's Hospital, Colorado. And Dr. Muther is also a member of this CFF Mental Health Advisory Committee.
All right. Hi, everyone. I'm going to get us started, and then I will pass it off to Emily. So the title of our talk is Mental and Behavioral Health Among Children on ETI. Oh, God. There we go. And we are very excited to be presenting some preliminary findings from the YETI study. And just please take a moment and look at the YETI that is juggling tricaftas. All right, so just quickly, did want to mention that this study is funded by Cystic Fibrosis Foundation Award, and that was to the STRC. And then Emily and I both have funding from the CFF, and I have some from NIH as well. Okay, so what is the YETI study? So it stands for Your ETI, and YETI was a multi-site survey study designed to better understand adherence to ETI among people with CF, ages 7 and older. Today, we're gonna focus on our pediatric sample, so we're gonna only talk about 7 to 17-year-olds. But I do wanna note that we have a lot of data available as well for adults. In addition to youth participating, we also had their caregivers who participated. So this was a fairly large study. Participants completed 2 study tasks as a part of YETI. So they completed an enrollment survey, and today we're going to focus on a survey that was completed during that part of the study. And then in terms of measuring adherence, they completed a daily diary for us. I'm not going to talk about that today, but that will be coming. All right, so our goals today are really to focus on one measure, and that was the CHETI. And it stands for Change in Perceptions of Health on ETI. And I'm going to get into it a little bit more in terms of the items. I'll show you some of the questions. But today what we want to do is focus on that measure in particular. We're going to go over findings from the adolescents themselves, 13 to 17-year-olds, and their report on the CHETI. And we're also going to present caregiver data as well. And then we're also going to take a look at how our adolescents and their caregivers, so in our dyads, how they sort of compared in terms of their responses. Okay, so these are the enrollment surveys. This is just sort of a sampling of different measures that were collected. Again, I'm going to focus specifically on the CHETI, but you can see that even in the littler kids, 7 to 12-year-olds, we had them reporting on body image and mental health. So we're excited to take a look at that at another talk. All right, so as I said, this is an STRC study. It was a quick enrollment period. It was from March to July of 2024. We're incredibly grateful for the STRC, for everyone's participation. We had 15 centers who enrolled, so a lot of participants. You can see we had 372 total participants enrolled. We're gonna focus on, again, the pediatric sample. I do wanna take a minute and talk about our eligibility criteria, because I think it's important when Emily gets to our results. So in order to be in the study, participants had to be on ETI for at least 18 months. So that means they were tolerating it. They could have changed their dose, but they had been on it for quite a long period of time. So keep that in mind. All right, so more on the CHETI. So the CHETI was really developed to evaluate patients' perceptions of how their health had changed since they started ETI. And a lot of the work from colleagues in this room went into informing the items on the CHETI, and I will show you those soon. But it was informed by the mental health side effects checklist, as well as a clinician survey. And then we refined the items with STRC clinicians and our community members as well. So briefly, there are 4 positive items. So that's getting more at before and after starting ETI. Did you feel hopeful, confident? Then we had 20 bothered by items. So when you think about mental health side effects, that's sort of where those items will be. Then after some discussions that we had with colleagues, we added 5 items that were yes or no, trying to get at, did participants start a particular medication after they had started ETI or talk therapy? And then finally, we had 2 open-ended items. And one looked at ETI mental health side effects, and the other was how participants were managing their mood or feelings. All right, so now we're going to do a couple red cap screenshots here just to be sure you know exactly what you're looking at. So the question on the CHETI was, please share how often you have experienced each symptom or feeling before starting Trikafta and in the past month. So each question is going to have this response option of before starting Trikafta and in the past month, and then they answer never, rarely, sometimes, often, and almost always. So again, trying to get at, is there a change in response, or does it remain the same from before starting Trikafta to in the past month? So these are our positive items: hopeful, confident, positive self-esteem. And these are going to be the bothered by items. So how often, from a caregiver's perspective, was your child bothered by sleep difficulties, by fatigue or lack of energy, by brain fog, and again, looking at before to in the past month. This is how often was your child bothered by feeling angry, depressed, anxious. And then these were the 5 items that got more at, were they taking a particular medicine, were they going to talk therapy, before starting Trikafta, since starting, or currently. Okay. And these are the demographics for the sample that we're presenting today. So this is 118 youth, ages 7 to 17. You can see this, what we would expect in terms of demographics. About 95% were white. You can see 55% reported a household income less than $120,000 a year. If you look at the screened positive, it does match what we would probably expect. So about 19% of youth are screening positive for depression, 16% for anxiety, 10% for behavioral problems, about 35% for sleep problems. But what's interesting to us was, I mean, it's all interesting, but I want to highlight this. When we broke it down in terms of ages, we don't have a lot of data yet on the younger kids. In fact, TIDES 2.0 is going to investigate this a little bit more. But you can see we have about 29% of the younger children who are screening positive for depression, 29% for anxiety, compared to 11% for teens and 7% for anxiety for teens. And Emily?
Okay. Thank you, Robin. Okay, so I'm going to just take a minute and orient you all to this sort of busy slide. So as Robin walked you through, we had 3 different categories of items on the CHETI. And these are sort of changes in self-perception, the more hopeful questions. And those are feeling hopeful, feeling confident, and having positive self-esteem. Those are the items. And then you can see each of those items on the CHETI were broken down by age category. So you can see the first bar are our children ages 7 to 12 years of age. The middle bar are adolescent patients 13 to 17. And then the third bar were our caregivers, and these were caregivers of our pediatric patients ages 13 to 18. So it was really interesting and important to us to look at what are the differences in these items across these different categories. And then you'll see 3 colors for each of these items. And the colors represent the green at the bottom are those percentage or frequency of participants in that category that reported a worsening on that item. So for example, if we look at feeling hopeful and you see in the adolescent bar in the middle, there's about 10% of participants that reported that they felt less hopeful or they worsened in that category after starting Trikafta compared to before they started Trikafta. And then conversely, the dark blue bars at the top are those that reported improvements on those items. So for that same example, you can see if you're looking at adolescents for the item feeling hopeful, you'll see that about 30% in that middle bar reported improvement in feeling hopeful after starting Trikafta compared to before. So hopefully that makes sense. And this is the way the next several slides are going to be. So just take a moment to sort of absorb all of that, and I'll walk you through this first slide. So you can see, while the majority of participants across these three categories didn't report any changes in their own perception for both changes in hope, changes in confidence, and having a positive self-esteem, that's that sort of middle section, the light dashed blue section. We did have participants who reported both improvements and worsening of those symptoms. And then what we wanted to make sure to call out is that we were interested in looking at differences between caregivers and the adolescent participants or the pediatric patients who were reporting on these items to see if there were differences in the way that caregivers perceived changes before and after Trikafta and what the adolescent patients themselves reported. So we used the Fisher's exact test with a significance level of 0.05, and we found that for both feeling confident and having a positive self-esteem, that responses differed. The adolescent responses differed from their parents when it came to these two categories, and that was statistically significant. So here you can see now we're getting into those bothered by categories that Robin mentioned, and this is, as she said, where we're really tapping into some of the mental health side effects that people may or may not be experiencing that were impacting them or that they felt bothered by. So the three categories on this slide are sleep difficulties, so problems with sleep, feeling bothered by changes in their sleep, fatigue or lack of energy, and then that category that CJ talked a lot about in her presentation, brain fog, forgetfulness, confusion, slow thinking, some of those more cognitive symptoms and changes. So again, while the majority of our participants and their caregivers didn't report changes in their perceptions of how they felt before they started Trikafta compared to how they felt after or how they're feeling more recently, we did see some changes here similar to what I shared in the previous slide. So these with the actual frequencies are the ones that were statistically significant and where there were statistically significant differences between the caregiver's response and their adolescents. So for those you can see sleep difficulty, we had about 20% of adolescents who reported worsening changes, feeling like their sleep was worse after starting Trikafta, 13% of caregivers. And similarly, when we look at brain fog and forgetfulness, which again is a really important category that we need more data on, and this is really just the perception of both the adolescent and their caregiver, what they remember, what they think were changes or improvements. 16% of adolescents reported a worsening in this category, and 9% of their caregivers. I also should note that we also had a similar percentage of individuals who reported improvements. So again, and we'll talk about this in the discussion, while the majority didn't report significant changes, and that's really great news, I think we also need to dive a little bit deeper and consider both the dark blue and the yellow categories. So more bothered by symptoms, these are really more kind of directly related to some of the mental health side effects and things that we are more routinely screening for in CF clinics. So things like feeling angry or irritable, feeling depressed, feeling anxious. And here you can see these were the ones that were statistically significant. So changes in depression and anxiety, where there were differences reported between the caregiver, statistically significant differences between the caregiver and the adolescent patient. And again, on both you can see our frequencies, 16% of adolescents reported a worsening in their mood, 20% reported a worsening in their anxiety from before they started Trikafta to recently. Similarly, we had about 9% of adolescents who reported an improvement in their mood, while 13% of their caregivers reported improvement in their mood. And for anxiety, we had about 10% of adolescents report an improvement in their anxiety, while 13% reported, caregivers reported that improvement. This will be the last of the busy graphs that I'm going to share, but these are those last few questions that Robin mentioned that we added after really wanting to understand, and I know there's been a lot of discussion about wanting to better understand what are people doing when they're experiencing, if they're experiencing these side effects. Are they making modifications to their TRIKAFTA? Are they adding or reducing some of the more psychological interventions that they've been on, whether it's medications or therapy? So here you can see at the bottom, we had 5 questions that we asked related to this. Taking medication for anxiety, we asked, were you taking medication before you started TRIKAFTA, and are you taking it now? Similarly for depression, ADHD, sleep problems, and then therapy. Were you attending any sort of psychotherapy or talk therapy before you started TRIKAFTA, and are you doing that now? The yellow bars at the bottom are those individuals who were not doing so pre-TRIKAFTA, but did start either taking medication or seeking therapy after. And the dark blue bar at the top were those that were taking medications before and then stopped after. So presumably those things improved, the mental health symptoms for which they were on medication or seeking therapy for improved, presumably. We'll talk about the limitations of this data in a second. And then for the yellow, that would suggest potentially that there was some sort of worsening for which they started new types of treatment. Okay, so this is a screenshot of what these additional questions look like. So we added a question that's asked, has your child, this was obviously for the caregiver, has your child ever stopped taking or altered the way that they take TRIKAFTA because of mental health concerns? And then we asked for them to say yes or no, and then to briefly describe the outcome. So these are just some samples of responses that we got. One of our next steps is, this really is sort of a teaser of this data, because we really intend to look at the qualitative data and really analyze it so that we can better understand these responses. But just a few examples, you can see one caregiver of a 7-year-old with CF reported, started TRIKAFTA, stopped after a month, started a lower dose 3 weeks later, gradually went up to a normal dose. Anger issues for the child were reported, and when first starting it did not come back after stopping and gradually starting again. And then a caregiver of an 11-year-old reported that their child was depressed, angry, and said things about wanting to die. They spoke with their doctor, and he cut the dose in half. So this is the first attempt to try to understand a little bit more systematically, what are caregivers, what are people doing when they're experiencing some of these symptoms? And then we asked, what do you do to manage your mood, feelings, and or thoughts? Similarly, we wanted to get sort of a summary of what are people doing when they're experiencing some of these symptoms, whether it's related to TRIKAFTA or not. And here you can see a few examples. An individual, a 17-year-old with CF, reported, I regulate through distraction until I feel calm or regular enough to deal with what caused the issue. I close my eyes, take some deep breaths, and think about the good things in my life. And then talking to my mom, reading, writing, drawing in a journal, seeing a therapist every other week was what a caregiver reported on their child. So as a psychologist, these are really exciting to hear and to understand what people are reporting. And I think the more we can kind of analyze the themes and understand this better, and the frequency in which this is happening, the better. Okay, so in summary, as I mentioned, as we were looking through those graphs and this very preliminary data, overall, participants reported that their symptoms remained in general about the same before and after starting ETI. This is a good thing. This is really important. We have a caregiver on our study team who reminded us that this is what we want to be seeing and hearing. And at the same time, we had smaller proportions of individuals who were in those yellow and dark blue categories that we need to understand as well, that we need to understand better and what those experiences were. Comparing adolescent and parent report, we saw that adolescents reported feeling differently about their changes in confidence, self-esteem, sleep, brain fog, depression, and anxiety than what their caregivers reported. I think that's both unsurprising and really important, because I think when we as multidisciplinary care team members are working with individuals with CF and their family, in particular adolescents and caregivers, we need to understand where there may be discrepancies and who's reporting some of these experiences. We know that care teams should prioritize discussions with adolescents about their experiences because they may differ from what the caregivers are reporting, both on the more positive and the more negative side. I think it's important for us to understand both perspectives. And then most participants did not report a change in psychotropic medication or engagement with psychotherapy pre and post ETI. So some of the limitations that are, I think, really important for us to acknowledge. We, as Robin mentioned, this was a self-reported measure on the perceptions that individuals had before, how things were before they started ETI and how they may have changed most currently now that they've been on ETI for a while. So there is a lot of potential recall bias as we're asking people to think back months and months, and in some cases years, to how things were for them as adolescents and children, and certainly for caregivers, how their child may have been 18 months ago can be really, really difficult. And so there's a lot of bias in there. This is also subjective perceptions. And that, while this is a limitation, it also is on purpose and part of why we created this measure, because we felt that separate from what objective data may tell us, changes in FEV1 and BMI, the perceived experience of people living with CF and their caregivers also matters, including if it's different than some of the more objective data that we talk about. And so we recognize that this is self-report, and it isn't asking people to remember far back, but we also wanted to understand people's perception. All of this happened in the context of COVID. I think we've been talking about this a lot. We can't separate changes in sleep and irritability and mood and say that that's specifically related to ETI, because we know a lot of this we were asking about around the time of the pandemic. There are developmental implications in this sample. It's normal for adolescents to feel more and less irritable on a day-to-day basis, certainly over the course of months. A lot of the things that we asked about, changes in sleep, worsening sleep, improvements in sleep, some of those things are just typical developmental changes for this population. And then this is a measure that's not validated, and so we developed it as part of this study and potentially are interested in doing the validation studies down the road. Next steps, the YETI study, the primary outcome is adherence. And so we really presented sort of descriptively one of the measures, this CHETI measure, but we really are excited to look at a lot of the relationships and changes that I reported that are associated with our primary outcome, which is adherence to ETI. We're interested in comparing additional changes between participant and caregiver report and the medical record data that we have. So some of the mental health screening data that centers have, we were interested in looking at that. As I mentioned, qualitative analyses of some of the comments and questions that we had. And then looking at demographic subgroup analysis. Where are there differences depending on different demographics? Really important that I acknowledge these are all of the sites that participated in the YETI study and that are part of the Success with Therapies Consortium, which is an adherence or self-management consortium supported by the CF Foundation. And then especially important, Robin and I really want to thank everybody whose name hopefully is on this slide and we didn't forget anybody. A lot of you were in weekly calls as we were developing this study, helped us with creating the slides, helped us thinking about how to interpret this data, and this really was a team effort, so thank you all.
Okay, thanks for all the questions on the app. We really appreciate it. Highly endorsed one was this question around correlation between poor sleep and worse anxiety, depression, or other mood behavior symptoms. I think getting at, do we think these are all the same patients who are reporting changes? Are they clustering? So any ideas on that?
Yes, really, really good questions and really important for us to consider as we look more at the data. I think that also will be helpful, as I mentioned in our next steps, looking at some of the data that was collected real time that we have with the mental health screening data, for example. Were participants reporting and caregivers reporting these changes in mood when they were being screened in clinic, and how does that reflect and relate to some of that. But yeah, I think it's a really important thought that a lot of these things are connected and grouped together and, related to, as I mentioned, age and that sort of thing. So teasing it out and trying to understand the data better will be important.
I think we're at time, so we'll go ahead. Thank you.
All right, and next we have Dr. Beth Smith, who is a professor of psychiatry and pediatrics at the Jacobs School of Medicine and Biomedical Sciences in Buffalo, New York, where she is currently the interim chair of the Department of Psychiatry and chief of the Division of Child and Adolescent Psychiatry. She's really busy. She's also the current chair of the CFF's Mental Health Advisory Committee. And with that, if I can get your slides started, there we go.
Great. Thank you for having me here today to talk about the GEMS, or the General Mental Health Screener. Hopefully many of you heard Dr. Alexandra Quintner's talk yesterday during the Psychosocial Research Showcase, which talked about the development of our GEMS. And today I'm going to talk specifically about the mental health concerns related to modulators and our new checklist. These are my disclosures and disclaimer. So we're going to talk about this along 3 phases. So the first phase was our concept elicitation. Next was cognitive testing of our measure. So once it was developed, talking through the measure with individuals to see if they understood the instructions and all the questions. And then phase 3 is preliminary validation. So phase 1 in the concept elicitation. So Alexandra talked yesterday about the diversity of our sample, and I was really excited to have such a diverse sample of adults with cystic fibrosis. We did this through many mechanisms, but one of them was using an effect called snowballing. So if somebody took part in our study, we asked them to share the link to the study on their social media and with their friends, family, colleagues as well. And so we had 60 very diverse individuals that did 1-hour interviews with Alexandra and I, where we were able to determine what is the most common and impactful mental health concerns to them. So what we did was we primed them with the PHQ-4, which is the first 2 questions of the PHQ-9 and the GAD-7. And wanted to know, in addition to generalized anxiety and depression, what other concerns were they experiencing? And these are the top concerns. After we coded thousands of snippets in vivo, the top concerns were procedural anxiety and disrupted sleep in 90% of our individuals. We also saw negative body image and trauma. 80% of the individuals experienced trauma, and we only counted trauma once. So many of these individuals experienced multiple traumas. 38 had medical traumatic stress, 25 domestic violence, emotional abuse, sexual abuse. We had somebody who was trafficked. So a lot of very significant trauma. ADHD came up as a top concern, but number 6 that came up was CFTR modulator side effects. And why this was particularly significant was because only 45% of our sample had been on or currently taking a modulator. So although it was only number 6, that was of a certain percentage. So this is something that really rose to the top for us. And again, we decided then we should probably have a separate checklist. But before I go on, I know Alexandra presented this yesterday, but please look that the lifetime suicidal ideation or attempts, 1/3 of our sample had a lifetime history. So just very important. So we then wanted to dig down into what kind of side effects they had. So with our purpose of sampling, what we did was we had these 3 major age ranges. And then what we did was we wanted to try to get gender equality in those age ranges. We wanted to make sure within each one of those ranges we had racially and ethnically minoritized individuals. We wanted to look at socioeconomic status, LGBTQI+, and we got a very diverse sample. So of those 60, 45 that were current or past ETI users are shown here. younger. So we had 21 women in the sample and 24 men. About 2/3 were white, 13% identified as Black or African American, 9% Hispanic, and then the other category. This was self-identified. So we had somebody who self-identified as Arab, Native American, French, Canadian, Inuit. So again, a very diverse sample. We had almost 1/3 of the sample that had low SES. And by low SES, we actually looked at the number of individuals in their household and their income. This was actually below the federal poverty level. 30% of our sample was below the federal poverty level, which again, I just think speaks to the diversity of this sample, because we also had individuals that were making, hundreds of thousands of dollars as well. So we wanted to make sure we heard the voice of everybody. And we had 1/3 of the individuals identified as LGBTQIA+. So after our thematic coding, these were the top modulator concerns in those 45 individuals. Uncertainty about the future and body image were tied for number 1. Interestingly, at least to me, uncertainty about the future was most common in those that were younger, and body image was actually more common in those who were older and men, which again, I wasn't necessarily prepared for, but in hearing some of the qualitative interviewing and the quotes, men had body image issues around their size, around not having as much muscle mass, of being shorter than individuals in their families. And so again, we learned a real lot in these interviews. Cognitive issues and brain fog was number 3. Insomnia. We heard about GI issues, anxiety and pain. They were all tied. And then mood swings, changes in mood, irritability, inattention, and eating challenges. And of note, we had 3 individuals who endorsed that they felt that they had acute onset of suicidal ideation or had had an attempt that they attributed to starting ETI. So I'm going to take you through a few of our exemplar quotes. So what we did was, when we were trying to determine what question we wanted to ask in each of these constructs, we went in and dug into these quotes and wanted to make sure that our questions were really matching what the individuals were telling us. So here are a few of the quotes. Uncertainty about the future. Individuals talked about it giving them a ton of anxiety. This idea of playing catch up. I didn't think I was going to live this long, and now, oh my gosh, I would have gone to school. I had a woman tell me she would have divorced her husband if she had known. I know, right? We heard lots of great personalized stories. This other one, the burdens and responsibilities of figuring out how to live as a person whose trajectory is all of a sudden different. I wasn't prepared for it. Again, thinking about the future, right? They're saying it's awesome, but just not prepared. And this next one, tezacaftor should come with a 401k plan because I didn't plan to retire. And the massive shock, and people even talking about that grief, that survivor's guilt. Grief that maybe they outlived people in their families, or they outlived other individuals, and now feeling that guilt and a sense of huge responsibility of, maintaining that person's legacy. So here's our corresponding question on the modulator screen. Having trouble adjusting to how my life has changed? Yes or no? And if yes, we ask about impact and frequency, and we'll get to the actual screening tool. Next, here's some exemplar quotes for body image. And again, we heard so much about body image, sometimes about size, rapid weight gain. But again, it being a struggle. I broke down for some time. We heard individuals talk about relational issues because they didn't feel as attracted to their partners and sexuality had changed. This being a daily struggle, feeling bad about their bodies. And again, I love the last quote because I grew up watching Mean Girls, but I felt like Regina George in Mean Girls because I gained so much and nothing fit. This idea of they rapidly changed sizes and couldn't necessarily cope with that. And then I don't have the extra money to change my closet again. So here's some of the questions that we are now asking on the modulator screener. Worrying about weight gain, not feeling comfortable about my body, and feeling upset about my body image. Brain fog and cognitive issues. I just can't remember anything. And individuals wanting us to know this is not typical forgetfulness. This is different. I can't always find the words. I can't remember things, I can't memorize. And we actually heard of a few individuals who stopped working, who had amazing jobs but were making mistakes and feeling really terrible and retired. So I'm going to read this quote because I think this is great. They're having trouble with concentration and brain fog. I literally don't remember things. Entire things I do not remember. Somebody will say, hey, you were just using that screwdriver yesterday. Do you remember what you did with it? And I want to look smart. So I want to be like, oh yeah, here it is. But in my mind, I'm thinking, it could be in the fridge. Literally, it could be in the fridge. I'm going to check my sock drawer. Nothing remotely works anymore. And again, I just feel like this was exemplar to what we were hearing those individuals that have cognitive issues talk about. So 2 questions on our screen, having brain fog and having trouble remembering things. Insomnia, there was a wide range from difficulty falling asleep to difficulty staying asleep, again, sometimes with that purge. But what we heard a lot about was this restlessness, this activation that was happening. Again, that quote, it's like a burst of energy. You have to time it right in the evening or the day so you're not having a burst of energy when you're trying to sleep. And that's thrown off my sleep schedule. It gave me more insomnia. Again, I love it. Trikafta is like an espresso shot in my body. And so again, we're seeing some of that flipping of the night and day doses, but lots of issues with insomnia. So questions on the modulator screen, having difficulty falling asleep, having trouble staying asleep, and having poor quality sleep. And then we heard a lot about mood swings, worsening depression, agitation, anger, snapping more, lots of relational issues, issues within partnerships, and also I had somebody who was fired because they had an issue with their boss. They became very irritable, short-tempered, and snappy. And again, people finding others more annoying than they used to, and feeling it was definitely attributed to starting the medication. And so questions on the modulator screen now are new or worsening depression, feeling agitated, feeling more irritable, and having mood swings. And then trouble concentrating. Even with those that had a history of saying they had attentional difficulties, that they wanted us to know that it was different. This was harder. It's way more than it used to be. I never really had these issues. And lots of trouble staying organized. So again, question on the modulator screen is now struggling to stay focused. And why do we need to screen for these symptoms? These are patient quotes because we're building the plane while we fly it, right? We need to figure this out. We need to be systematic about it. And we didn't know what we didn't know, and now we do, and now we need to screen for it. But this one, it's so hard for me to discuss it at the CF clinic. There's enough things on the checklist, right? And then you bring something like this up. We actually had somebody fill out the checklist, and they gave zeros on the whole modulator checklist. I did the cognitive interview with them. They had lots of symptoms, and they said, I don't want my modulator to be taken away. I've done so well with my physical health, not thinking that it can be about a partnership, right? That nobody's taking the medication, nobody's taking that dose, but if you're having insomnia, maybe there's things we can do. But he was very, very clear that he was not going to tell his team because he was so fearful of having it taken away. And so again, high stakes, but if we're not asking, they're not telling. So here's the initial draft that we have of our modulator screening tool. You'll see we ask, did this concern either start or get worse while taking your modulator? If the answer is yes, it asks how often has this been happening lately? Never, sometimes, often, or very often. And if yes, how much has this been bothering you? So again, frequency and impact. And it asks about those domains: sleep, weight, and body image, concentration, mood symptoms. We actually had 2 questions that tried to address symptoms of physical functioning on mental health, and you'll see that those didn't necessarily pan out in our next phase of cognitive testing. But this is our initial screen in phase 1. So next we went on to phase 2, our cognitive testing. Again, we did our purpose of sampling and had a very diverse group. This is a separate group of 23 individuals. We had 14 females and 6 males, 2 individuals identified as non-binary. 73% were white. 3 were individuals identified as Black or African American, and 3 mixed race, either Hispanic and or Black or African American, and 64% were on modulators, and those are the ones I'm going to talk about. We also gave this group the PHQ-9, the GAD-7, and the SDMT. So for those of you who don't know the SDMT, it's the symbol digit modalities test, 90 seconds, and essentially it has lots of different symbols, and under each symbol it's like 1, 2, 3, 4, up to 9, and essentially they have to match the symbol and tell the number. So if it's a C and it's a 1 and that C comes up, you have to say 1. And it's 90 seconds, but it gives us a brief look at like their concentration and their ability to focus. And what we found here was that our individuals are at least a standard deviation below normative samples. So in this second round, we had 8 individuals not on modulators. So again, I didn't look at them in my study, but we looked at them in the GEM-CF tool. We had 12 individuals on Trikafta, 1 on Orkambi, and 1 on Kalydeco. 3 had decreased the dose because of mental health side effects. 4 changed the timing, flipping the dose. 3 had discontinued and then restarted. So in phase 2, we did those cognitive interviews. And again, my favorite quote, trading my lungs for my mental health. Lots of individuals had felt like that, but didn't feel like they wanted to necessarily express that. So after our interviews, we did 2 iterations of interviews. 22 individuals were interviewed, and this is how our tool changed after that time. So having poor quality of sleep was actually changed to having racing thoughts while falling asleep, because this was much more of the construct we were hearing about from modulators, that activation. Worrying about weight gain, we actually changed to worries about weight changes, because we had a few individuals in the cognitive testing. We had that said they lost weight or felt like they lost their muscle mass. So we wanted to make sure we were a little bit more weight neutral in that, so we could account for any weight changes. Feeling more irritable was changed to feeling angered. And again, that was after individuals said, it's more than like a typical irritability. I'm really angry. Worsening depression and anxiety were changed to new or worsening anxiety or depression, and we bolded start or get worse while taking your modulator. Not feeling comfortable about my body was collapsed, because we were picking all that up on changes in weight and feeling upset about my body image. And the 2 constructs on how physical health impacts mental health were eliminated. It just didn't pan out right. So this is our final version of our GEM-CF. Now, final meaning we still have to go into some validation. But again, it's a yes, no. So if it's yes, then we ask about how often this has been happening and how much it's been bothering them. And so our next phase is our preliminary psychometric validation. And the good news is, as soon as we get back from this conference, we will start this. What we're going to do is the same diverse 60 individuals all said they would participate in this phase. So those that helped us with those interviews are going to get the GEM-CF. If they're on a modulator, they're going to get our checklist. We're going to get their SDMT scores, PHQ-9, GAD-7, DSM cross-cutting measure, and CFQR. And we're going to do some preliminary validation and evaluate the internal consistency of our measure. So again, just in conclusion, we had a really highly diverse sample. I'm so proud of this sample, and we were able to elicit common and impactful mental health comorbidities. And neuropsychiatric adverse events rose to the top, and hence we have this new screener that we will be validating. I have to shout out the team. This beautiful GEM-CF symbol was created by Tara. Thank you, one of our great research coordinators who's sitting next to Robin. Again, but some of the best research coordinators I've ever worked with, Alexandra and Anna, just a fantastic team. We have a great advisory board, Dr. Ed Kanda, Dr. Nowakowski, Laura Tillman. They helped us from the beginning, like even in just this concept of having this screener and every step of the way. But I really want to thank those individuals, those 60 individuals. And I'm going to get a little teary because they shared such personal stories. And I really felt privileged for what they shared. And sometimes said, like, I've never said these things aloud, and the way some of what they shared. And it was just, they invested their time and energy and trust in us when we did this. And so I'm so hopeful we can give them back this great product. And I'm excited to share our tool with them in phase 3. So thank you.
Okay, thank you so much. The biggest question seems to be availability of the questionnaire to the community.
So we want to share, Alexandra and I want to share this tool. What I would ask, I know you took pictures of the tool, and we want you to use it, but if you could give us just a few months, because we want to get that preliminary validation, because we might drop an item or two to make it a little bit shorter or collapse something. So we will share it out. So, my email address was up there. You're welcome to email me and say, like, I want this. And as soon as we have that preliminary validation, I am willing to share it out. And then what I'd like from you, though, is for you to share back with us. How is this working in your clinic? Is it feasible to give? How often are you deciding to give it? So we can gather that data and then kind of share it back. So we want to share it with you, but hope that you share back with us. So thank you.
Perfect. One other question I think a lot of us have in the room is if you could just tell us a little bit more about recruitment strategies or how you were so successful.
Yes. So what we did was we recruited from lots of different sources. And one of the things we did was, we created a demographic screener, and that helped us to get who we wanted in that purpose of sampling. And then individuals like Community Voice pushed that out. Anna and I attended the CF Saturday group, which is for individuals over 50. And then we got a rash of individuals completing the demographic survey that were over 50, the National Organization of African Americans with CF. So we really hit widely, and we used our advisory board because they have connections that we don't. They put it out on their social media, asked their social media friends to put it out on their social media. And then this idea of snowballing. There were a lot of individuals that thanked us for the interview. I was trying to thank them, and they were thanking me for listening, because that was, it's so important to them. And I often said, well, great, if you really enjoyed this, can you share this? Can you take the link that we sent you and share it out? And I know both of us got somebody when we said, how did you hear about it? And they said, oh, a friend of mine said, you have to do this. And so it was great. But we had hundreds, 400 or 500 people probably fill out our demographic survey. And so we were able to really sample for who we needed. And so as we got enough females, then we looked for more males, or as we got, again, in the different ages, calculating the socioeconomics, it really allowed us to make sure we were hitting everybody.
Go ahead.
I just have a quick question. You mentioned that you saw more men showing body image concerns than you expected. Did you see a gender difference between the kind of body image concerns that were being expressed there?
Yes. So definitely, we definitely did. So for men, the very common theme was around just growing up being smaller than their peers. A lot of them talking about the height in their families and them being shorter statured and smaller. But we heard a lot about muscle mass. And so that came up again more than I would have, more than I thought. But again, in the GEMS part of it, we also heard about individuals with scarring. Men, one of the gentlemen, Alexander had a quote yesterday, has not taken his shirt off in front of his wife. Right, married for many years in that intimacy, but just felt like his torso was a roadmap, and a roadmap that he wasn't willing to share. So yeah, we heard a lot about it, but I think it was more, due to their size and being smaller. Whereas with ETI, we heard more about women and the rapid weight gain and the shift.
Okay, thank you so much.
All.
And next we have, I am choked up from just that. That was such an incredible presentation. Thank you so much, Dr. Smith. Next we have Dr. Anna Georgopoulos to discuss strategies on symptom management. Dr. Georgopoulos is an associate professor of psychiatry at Harvard Medical School and the Mass General Hospital Cystic Fibrosis Center in Boston, right here. She leads the Education and Training Subcommittee of the CFF's Mental Health Advisory Committee and is our chair of our PRIME group.
Thank you very much for that introduction, and thank you all for coming today. I'm going to be talking about strategies to manage neuropsychiatric symptoms associated with CFTR modulators. So we've heard a lot about this now. Now, what do we do about it? This is our disclaimer. These are my disclosures. I will also point out a disclosure that this presentation will describe off-label use of medication, including ETI. So how do we proceed in uncharted territory? Well, I've had this slide and it said uncharted territory, and I had to add semi-uncharted because, look, this is not so uncharted now. We're charting it, right? Evaluation and management are challenging, right? Our evidence base is still limited. People are individuals, and their perspectives and their experiences vary a lot. There are a lot of confounding factors. We're all complicated people. We have personal histories. We have stressors. We all went through COVID-19. That was a huge external factor. CF can be complicated, and the medications for CF can be complicated and cause their own side effects. Psychiatric medications are complicated. But this is not impossible. If there is any group of clinicians that can figure out what to do in the face of limited evidence and complicated scenarios, it is the CF clinicians, right? We deal with this every day. What do we do when somebody has a liver problem on ETI, right? We say, they already had liver problems, right? Is this another medication? What's going on here? And there are ways to sort this out, right? And so we're going to talk about that. We monitor closely. We carefully assess. We have a careful differential diagnosis. This is not just about a checklist, but like, what's the next step going to be now, right? And thoughtful collaboration between those providing the medical care and the mental health care. And actually, we do have standards of care now that address this issue. So our European CF Society and CF Foundation mental health guidelines, we made those 10 years ago. We didn't have ETI at that time, right? But the standards of care for the European CF Society have been updated in 2024. There's a series of 4 wonderful papers that have been published. Paper number 2 deals with variant-specific therapies, such as ETI, and how to manage adverse effects. And mental health is just one of a series of kinds of adverse events that can occur. And so statement 27 in this standards of care document is, when initiating CFTR modulator therapy, people with CF and families should be encouraged to promptly report any significant physical or mental health changes to the CF team. Easy enough. And mental health should be monitored, so including screening for depression and anxiety before and no later than 3 months after initiating variant-specific therapy. And you could argue that's kind of the bare minimum. We've seen that there's lots of other kinds of changes that people report. And when someone does report a change in mental health, let's do a careful assessment. Okay, so what are some of the questions that people could ask? I'll refer you to this paper. The table is drawn from this paper by Evelyn Baroud, Nivi Chaudhary, who's not here today because she just delivered twins, and we looked back at our adults with CF up to a certain time point who had been referred for psychiatric care, and to see whether, and were taking ETI to see whether there had been changes in their mental health, and some had had improvement, some had had no change, some had changes that it was, or possibly related, and then, 16 had changes that were probably related. And I think we saw that as part of a chart that CJ showed a moment ago. So I'm not going to go through all of this, but these are just the kinds of questions we would ask with any kind of psychiatric or mental health situation that might arise. So they're really not that different. And again, we're thinking about timing. We're thinking, when we think about relatedness, right? Has someone, did something get worse when the dose went up? Did it get better when the dose went down? Did it stop when the drug was stopped? Did it restart when the drug was restarted? This is not any different than the kind of assessment that we normally do for other medical concerns. And what are some of the key principles of clinical management? Well, one is acknowledging that there is uncertainty and how that feels to be, building the plane as we're flying it, right? Both in terms of, do we think this is related in this situation? What do we say about how we think this might go? what the next steps are, to have those discussions around potential interventions. This isn't a one-way street of here's what I'm telling you we have to do. This is co-managing, co-developing a management plan and taking into account the pros and the cons, the risks and the benefits and the preferences of that person and family in front of you, knowing that people's risks are going to vary, right? If one person started ETI when they were on the transplant list and came off of it versus someone else who has an FEV1 of 105%, those risks might be different for saying, let's see what happens if you stop the medication for a few weeks. And also, different people will make different decisions in the same scenario, right? So my tolerance for a risk, either the risk I know or a risk I don't know, might be really different than yours, right? We might make a different decision with the same set of circumstances. And so that's really also important to take into account. And then we want to be as systematic as possible. Look, sometimes it's not possible. Something's happening really acutely. We just have to kind of do multiple things to try to get things under control and then backtrack later to try to figure out what worked. But for the most part, right, we can change one thing and we can see how that works and then we can go from there. And we can try to track interventions and outcomes in a systematic way. We may need to be seeing people more often than we otherwise would. And this is just an example of a mood chart. This isn't CF specific, but it shows that there are, ways out there. This is just from the internet, right? There are lots of ways we can track apps and other things where we can track sleep and mood and anxiety and medication changes and all of that so we understand what's going on. So what kind of intervention strategies could we consider? Well, first of all, there is always the option of no intervention, right? And this is like to Beth's point, right? If someone brings something to us, it doesn't mean we're going to take their medicine away, right? We might say, you're tolerating this okay, or in your scenario, you really just want to leave things alone. Some people's mental health actually improves, right? Maybe we even say, do you want to start to reduce your medication and see how that goes? Or the symptoms are just tolerable. But the second set of interventions would be psychosocial interventions. So support around adjustment and coping. Some of those modulator-associated symptoms that Beth showed, some of those are, they're not things that we're thinking are direct biological impacts. We're thinking those are things having to do with our psychological adjustment to starting a modulator, right? How do I feel about my body image or my changes in roles or, now, it's different with my family, right? My mom's doesn't know what to do because she doesn't need to take care of me as much, and that's affecting our relationship. So we can provide support around that. We can use behavioral strategies that we would typically use, like strategies that we would use for insomnia for other reasons, maybe helpful for insomnia that got worse when someone started taking a modulator. And again, we can use the usual psychotherapeutic treatments that we would use for observed symptoms. So if someone is having more depression and anxiety, we can try some cognitive behavioral therapy directed at depression or anxiety to see how that will help them. And then next, we also have psychopharmacologic interventions. Again, we're employing the usual strategies that for the symptoms we're seeing in front of us. So here would be like an example, an adult who starts ETI, and beforehand they have depression, they have anxiety, they have ADHD, and those are well managed with an SSRI and bupropion. And then afterwards, they start ETI, their lung function improves quite a bit, but their mood gets worse, their anxiety gets worse, they're feeling really kind of apathetic and disinterested. They're having word-finding problems, memory concerns that they never had before, even with the ADHD. They're having trouble sleeping that they didn't ever have before, and really vivid dreams. So how might we intervene? So we can increase the SSRI and the bupropion dose and, have a good response for depression and anxiety, and add a stimulant medicine, right, that wasn't necessary before. The Wellbutrin kind of did enough for the ADHD, and now, kind of executive functioning supports and things like that, but now we add a stimulant and the ADHD symptoms improve. And in this case, insomnia, improved over time. The person was able to sleep better without a specific medicine for sleep, and decided, there's still cognitive concerns, and it really takes longer for me to retrieve words and things like that, and I'm having vivid dreams, and I can deal with that, and I'm staying on ETI. Okay, another option is to adjust the modulator and see what that response is. So That could be discontinuing, that could be switching back to a previous modulator, that could be an off-label dose change. We don't really have the PK data to guide us so far. So far, the PK data that's emerging seems to say there's a lot of variability, right? But it's not like here's the level you need and we can say this is your right ETI, level of E and T and I to say this is the right dose for you. But again, this is something that's being worked on. Having a trial like this might also tell us something about relatedness, or at least be informative in relation to relatedness. So if someone stops, it's not saying you have to stop this forever. It's, if you're interested in stopping, let's see what happens, and then you can decide about restarting, or restarting at a lower dose or more slowly. But of course, it risks the loss of the benefit for the CF symptoms. And again, this may have different implications for people depending on their health status. Here I showed a number of studies that, and two in particular, Spolatini and Ibrahim studies, use sweat chloride as a proxy for how well the ETI was still doing what it needs to do. And that's an approach that people could consider taking. Okay, so back to this ECFS Standards of Care paper. This is the same one I referred to a few minutes ago. I'm not going to go through this whole chart. I just wanted to tell you there's a table 4. And again, all of these different kinds of adverse events, mental health adverse events are one subset of these. And actually, there are protocols in here that are suggested by this group for how you might think about this, about dose adjustment, discontinuation, reintroduction, other actions you could take. And these are based on the case studies that are in the literature so far. Doesn't mean this is going to end up the right way to do it. This is one of the key research gaps, right? That what are the dose adjustment strategies that are going to help us optimize reducing side effects and maintaining those modulator benefits. And also, although, clinically we can see that that there are strategies that are effective for addressing mental health symptoms with psychotropic medications or psychotherapeutic interventions. We don't have systematic data on that, and it would be useful to have more study. And we have a manuscript under review currently that will talk about a lot of other research gaps that we have. So speaking of research gaps, some of you may have seen this morning the results of the ivacaftor, tezacaftor, ivacaftor trials. We expect, as CJ said, approval by January 2nd. The FDA is slated to decide whether they want to approve this drug. It is going to be similar to ETI, but it is once a day, and it does have some differences and potentially more potent change in sweat chloride, which may or may not translate into clinical benefit for people. So what we plan to do, this is a study that we're organizing with the CF Foundation, and CJ Bathgate and Janice Stoll will be PIs with me. Kristen Riekert and the SDRC will be the data coordinating center and the clinical coordinating center. And this is a study that is going to have, we hope, some decentralized recruitment. So keep this all in mind, as you as this drug is approved and as you have folks who have discontinued ETI or on reduced dose for mental health reasons, or people who for liver reasons have discontinued ETI or gone back to a previous drug. We want to take those folks and see what happens as they start VTD. And do some close monitoring, symptom management. So for some people, there'll be a very light touch. All they're doing is remotely doing questionnaires, easy peasy. The next kind of layer of participation would be coming in for 2 visits, like at time 0 and at 1 month, maybe getting some blood work for some of these, for biobanking for some of these kinds of studies that CJ was referring to, where we could look at inflammation, we could look at stool and microbiome and sputum and all of those things. We hope that that will be part of the study. We'll hope there'll be part of a study with neuropsychological testing that again will be optional. And depending on resources and availability, maybe we can do some PK work and also some neuroimaging to try to address some of those on-target effects that I think were alluded to in the questioning earlier, right? So are there changes in mental health that aren't an off-target effect, but have to do with the fact that CFTR is being modulated in the brain, right? And for example, the GABA receptor we know is a chloride channel. And so if we're modulating CFTR, what's happening there? And does that tell us something about what treatments might be most effective. So I wanted to let you know that we do have resources. The Mental Health Advisory Committee has a set of tips for teams for different age groups to help you think about how to discuss these issues with families. You can find these at cff.org in the resource library at my.cff.org. If you are not on my.cff.org, you can register if you're a member of a care team. If you can't register, mentalhealth@cff.org, email us, and we will help you get registered so that you can get all of these wonderful resources that we have, including modulators and mental health. And also, this is something that might be helpful for patients and families. This was done for the Patient Association in Quebec, but there is an English version that's also in the my.cff.org resource libraries. If you search for CFTR modulators and mental health, you'll find this resource. And so I wanted to finish up with the perspective of an adult with CF, Liz Perry, on kind of all of what we've been talking about today. So I will play that next.
Hi, my name is Liz Perry, and I am 48 years old, living with cystic fibrosis. Have practiced as a mental health social worker and have my LCSW. I do have a rare mutation of cystic fibrosis. And so when they put me on a modulator, they gave me Symdeco. And I basically had the trikafta experience with Symdeco and with, the purge, everything. And in fact, the first pill I took, within an hour, I was like, I told my husband, I said, something is happening to my body. I don't know if it's good. I don't know if it's bad, but something is really, really happening here. And so I went out for my little walk and I ran 4 miles. The pulmonary aspects of this Symdeco was just phenomenal. But within a week, I started noticing real panic type experiences and symptoms that was really unfamiliar to me. And I called a colleague of mine and shared with her what symptoms I was having. And she said, to get on some medications immediately. And I went to my primary care doctor and started some medications. It did work, or seemingly worked, and managed my anxiety. At that point, I also was on CF Facebook pages and looking at the anecdotal evidence of, other people really experiencing mental health side effects from their trikafta modulators, anxiety, depression, suicidal thoughts, all that. And really, I thought, not me. I'm a therapist. That would never happen to me. Or I would just know how to handle it. I just was really in denial that it could happen to me, or that it was already actually happening to me. Because I think that it is so easy for us, and also for the CF team, to say that anxiety is probably a result from an extended life and this life transition. And so I think it was really easy just to say that mental health issues were just part of this adjustment to modulators. It's just, I think having these modulators, it is just so easy to get caught up in the pulmonary miracles and the PFT scores that we're getting, that I think that just with that hyper focus on the pulmonary stuff, that it kind of gets lost in the shuffle, that there is this real mental health issue going on with us taking the modulators. I think that I was lucky to be in a center where, when I started having more of my symptoms, that I had a psychiatrist and a therapist already within our center, and was able to be fast-tracked into the right care. And I really wish that all centers could either have that within their center, or at least be able to have a social worker, or be able to have some outpatient providers that are highly educated in CF, or could be educated in CF, and these modulators and the social workers stay in the loop. And so I think having that in our center like really made such a difference for me. And then it was so validating that someone was saying, yes, this is a side effect to the modulators. You know, it's so easy for us to just tolerate symptoms, invalidate symptoms, rationalize, chalk it up to other things. So to have somebody really say, yes, no, this really is a side effect from your modulator. Oh my God, it was such a relief for me. So my symptoms really included massive, very severe insomnia, massive anxiety, mood changes, increase in already existing PTSD symptoms, memory issues, and just a feeling of stuckness. And I love that we are able to do psychiatry with therapy. You know, that's always, you know, data says that that's really the best way to go, and that we did find a cocktail. You know, we did do trial and error of medications, and I have had really just a relief from the mental health symptoms caused by the modulator. So there is really hope that you can stay on the modulator and have a freedom from the mental health aspect. Our mental health as CFers is what generates our fighting spirit to survive and thrive. Oh, this is gonna make me emotional. Our mental health is what keeps us going and keeps us feeling hopeful. And so I just hope that this mental health piece with the modulators will be taken more seriously and given more thought in how your center is going to support your CFers and this need.
Anna, we got a couple questions about, is retrial enrolling yet?
Not yet. We are moving as fast as we can. We want to be up and running when that, you know, new modulator comes out. So stay tuned.
All right, thank you so much.
I was just going to ask,
please.
is that going to be age 12 and up? I was just
6 and up.
6 and up. Okay, good. But then how will you do like mental health screenings and stuff?
Oh, we have our ways.
Okay.
My goodness, these just keep getting better. And last but not least, by any stretch of the imagination, I'm going to start here. We have Dr. Alexandra Quittner to give us some ideas on future directions. She is a senior scientist and pediatric psychologist at Joe DiMaggio Cystic Fibrosis Center, Cystic Fibrosis Pulmonary Sleep Center, and she leads the research subcommittee of the Cystic Fibrosis Foundation's Mental Health Advisory Committee.
Thank you so much to the Program Planning Committee and to the chairs of this session. What an amazing session. I have loved every moment of it. And just to comment on that video we saw, we heard so many people in our GEMS interviews who were having modulator side effects who could not bring it up at clinic, who were sort of dismissed and said, you should be grateful that you have this wonderful medication, or, you know, you're really imagining this, but not validating these side effects. So that's one message in that video that I really hope you all take home, is to talk to your centers and educate them about the importance of listening to people when they describe some of these side effects they're experiencing. Okay. So, TIDES 2.0, I'm going to try to answer this question in the affirmative. Is it time to screen mental health in younger children? And I want to thank my wonderful colleague, mentor, Dr. Beth Smith here, who is the PI too. Okay, this not, which, oh, this one, okay. So I want to talk about the first TIDES study, the International Depression Anxiety Epidemiological Study, a mouthful. Published 10 years ago. TIDES is 10 years old. It was published in 2014. This is 2024. One of the largest epidemiological studies conducted in cystic fibrosis. It was a landmark study screening over 6,000 teens and adults with CF in 9 countries and 4,102 parent caregivers. And many of the people in this room helped make TIDES happen. Without TIDES and without all of your support, much of what we have heard today may not have happened. It documented rates of depression and anxiety that were 2 to 3 times higher than in community samples, and that was a very important piece of data to publish. So TIDES was really a project that included the prevalence study, so being able to say how highly prevalent depression and anxiety were in the population, which then led to guidelines so that we would have guidelines to address, to screen mental health symptoms, to do potential interventions to address them, and finally, the dissemination and implementation of our mental health screening guidelines. And again, I want to thank many of you, most of you in this room, because you are helping us to implement and you are doing the screening. TIDES put mental health on the map for CF care. It is now integrated, not just in the United States, but in Europe, much better, in Australia, in Canada. And again, I want to just say, having been at this conference and thinking about what we have developed over these last 10 years, this is a remarkable group, and the quality of these sessions and the research and clinical work being done is just beyond belief. So I have to take you back in time. Many of you in this room were on the guidelines committee. Take a look at your picture from 10 years ago. Many people, Amy Mueller, Beth Smith, Anna Georgiopoulos, Kathy Sabadosa, and you might see back there Mike Boyle was on our committee to do the international screening guidelines. So this was so important to publish these screening guidelines, and it enabled us to really implement and disseminate mental health screening. So in our guidelines, I've yellow highlighted the one that most of you are familiar with, at least annual screening for depression and anxiety with PHQ-9 and GAD-7, starting age 12 and up. But for our younger children, 10 years ago, there were no national guidelines on screening children under the age of 12. And in 2022, the U.S. Preventative Task Force recommended screening all children in primary care for anxiety beginning at age 8. So that shows you that there's a growing interest in mental health screening in younger children and an awareness that mental health problems are emerging in this younger cohort. With the introduction of ETI, you've heard today, for young children, concerns have emerged about side effects related to sleep, emotional and behavioral concerns, and cognition. And the YETI, CHETI, whatever it's called, study really highlights some of those side effects. So we did a survey through our Leadership and Design grant where we asked pediatric centers, are you screening younger children, children under 12, for some of these mental health symptoms or behavioral symptoms? We had 71 centers report, and you can see here only 26% of those centers were doing any sort of screening, about 19 centers. And by contrast, 95% of our centers are screening 12 and up. So I wanted to share this picture with you. I just came back from being in Chile, and we had centers from Uruguay and Chile. This is a young girl before, the left side of the picture is before she went on ETI. And you can see she's got an IV pole, and she's drawn sort of being in the hospital. And then después, after she started tezacaftor, and you can see vacations, you can see her dancing with her family, lying on the beach, and how happy she is about tezacaftor. So despite the fact that we're going to talk about symptoms and side effects, we also recognize the positive benefits of this transformational medication. So I'm presenting some data from Emily Muther, University of Colorado, and from my small center at Joe DiMaggio on the pediatric symptom checklist. Both data sets suggest that these younger children have higher rates of internalizing depression and anxiety and externalizing symptoms, acting out, impulsivity, irritability, anger, and attention difficulties. And if you look at the green bar over to the right for the Joe DiMaggio data, 17% of my children that I assessed had attention problems above the clinical cutoff. So this just is a signal that we in fact have problems in our younger children on the pediatric symptom checklist. So the good news is that we got funding to conduct TIDES 2.0. to screen mental health symptoms and behavioral issues in younger children. Beth Smith and I are launching this, and we have an amazing core team. They're all listed here below, and they're names that are very familiar to you. So the innovations of TIDES 2.0 are random sampling to ensure representative of our study population, oversampling racial and ethnic minorities, and using the CF registry data to use sampling weights to make sure that we have an unbiased sample as much as possible. The other incredible innovation is AIM-3, which is Dr. Georgiopoulos, who is the lead. We'll be doing a mixed method sub-study of modulator-associated symptoms in these young children. So these are children 18 months through 11 years. So we'll be doing qualitative interviews as well as quantitative data on the frequency and severity of these ETI side effects. So 600 children we're going to enroll at 16 centers, 18 months through 11 years, and the stars and the geographical map show you where they'll be. And within each center, we're going to use stratified sampling to make sure we oversample racial and ethnic minorities and those living in low-income households to promote equity in CF research and clinical care. And I think promoting equity is critically important. Beth Smith talked about what we did to get that purposive sampling done in the GEM study. One thing I wanted to mention, it takes a little bit more time to enroll and assemble a diverse sample. So one of the things we need to tell to our grant funding agencies is to actually get a diverse and representative sample, you have to give us a little bit more time to do the recruitment and enrollment. So here are our study measures, which you might be interested in. We're going to have a diagnostic measure, and that's the BASC, which you can see on the left, early childhood, 18 months through 5 years, school age, 6 through 11, and approximate time to complete. So the diagnostic screener will only be done at time 1. This is a 3-wave study, so it'll be probably once a year over 3 years. And the diagnostic screener, the BASC, which is 139 items for the parents or 175, only one time. But then against the diagnostic screener, we will map our much briefer, much more feasible screening tools, the PSC, the Pediatric Symptom Checklist, which has a preschool version and a school age version, and also the PROMISE measures. PROMISE has measures, modules on depression, anxiety, irritability, sleep, and cognition. They're very brief. They've been very well validated. We're going to look at the CFQR. We have a preschool form that actually the kids can point, and it's done on a computer, and they can self-report, as well as the parent proxy. And then we have the CFQR and the school age measure. And then we have a measure of procedural anxiety in there, that's parent report. I think that's very important because we have a high rate of procedural anxiety and distress in our population. And then finally, the Well-Me and the Naranjo scale, we will be using those in our qualitative assessment. And we're going to look at parent mental health, because we know from the first TIDE study, if parents were depressed and anxious, it was far more likely that their adolescents would also score in the elevated range. So we'll be looking at the contribution of parent mental health. And then finally, the child self-report, where they're able to do it. The preschool CFQR is the measure for the really young ones. And then we have the PSC, the BASC modules, and the CFQR for school-age children. So I want to thank our parent research partners first, Rena Barrow, Jorge Castro, and Dana Kibble. These are parents of young children in the age range 18 months through 11 years. And these are the wonderful centers who will be collecting the TIDES 2.0 data. And Anna leading AIM-3, and I want to point out my wonderful statistician, David Barker, who's at Brown University and was a graduate student of mine and is just an amazing statistician. So with that, thank you so much.
Okay, so one question, Dr. Quittner, is if other studies can join the TIDES group, or if that's an option.
You know, that's such a good question. I should have probably thought about that. Right now, we have funding for 16 centers. Would it be possible for people to be able to collect data and add it into our database? What do you guys think? We would have to really talk about that. We are building the REDCap database. It will be beautifully built by Dave Barker. And so it's possible that we could share that with people who are interested in collecting the TIDES data. So that might be one thing that we could offer. We're also offering this to the European CF centers, to the Canadian and Australian centers. And, you know, if I could leave you with one idea, it would be to start screening, start using the pediatric symptom checklist, or start using the PROMIS modules. These are all free, brief measures, and they've all been translated into Spanish. And multiple languages, but we mostly need Spanish, but many world languages. So I would urge you to at least begin screening.
Okay, so one question that we got from the group was across all of these excellent talks, there's also a shift in the CF care model to potentially have less touch points with patients. And so how do you balance or any concerns about mental health care, these questions and conversations about side effects, if the care model is sort of shifting to where you have less opportunity to interact with patients, and we know mental health can be so variable across time?
Yeah, I would love to have Stephanie Foligno comment on that. Would you like to, yeah.
That what's being proposed in the care model paper and the treatment team paper is that there are not less being recommended. There may be fewer in-person touch points, but that should not limit in-between contacts that are really important to maintain that continuity of care and continuity of assessment across all domains, physical and mental and other sorts of health functioning domains.
Right, and the other point would be, if you think back to the slide where I said you might need to see people more frequently, like, so if someone is having mental health challenges, whether they're related to modulators or not, that might not be a person that you say, let's go to less frequent visits. That might be someone you actually say, let's have more frequent visits, right? An individualized planning.
Using your telehealth. Yeah, telehealth. That's the other thing. When some of our adults don't come in as often, or adolescents,
We encourage them to do telehealth visits in between. So maybe we don't see them quarterly in person, but our rule is you have to have at least 2 in-person visits, but you're allowed to do 2 telehealth. Now that's for our adults once they're 18. So there is some flexibility in using telehealth.
And I was just saying, like, the benefit of telehealth, I don't know if any of you have had this experience, but you get to see in the kids' homes, right? Like, I have seen things and heard things in the background that have been grist for the mill, and sometimes get to do that behavioral parent management, like right at the time, or the kid that won't get out of the shower because they feel contaminated. I can work right at the moment. Again, I'm not in the shower with them, but you know, there is some advantage too of getting kind of behind the curtain.
not the shower curtain. Not the shower curtain. Yeah. Just checking.
Good clarification.
It's okay to get in.
Another just sort of overarching question. So I think a lot of folks are interested on the clinical side, or just maybe even advocating for mental health conversations in their team. So any advice, practically, anecdotally, you have for teams on how they can have conversations about mental and behavioral health with people with CF or their families who are concerned about side effects, they're concerned about Vanza, they might have experienced side effects before, that's on all of our minds. So any thoughts on that?
So we screen side effects every visit. We do mental health screening every visit. I love my mental health coordinator, and we screen every visit, and people just know we're going to do it. And by using our checklist, and now we're going to use our new one, it opens up a conversation, and then you feel free. They feel free to express what's going on, and also validated that whatever's going on, I would like to hear about it, and let's see if that's a side effect related to ETI. We've done lots of dose changing, lots of
flipping morning and evening dose. I would say in my adult clinic, 20 to 25% have side effects that have required some sort of dose change. So by opening up that conversation, we started that 2 years ago. At first, my pulmonologists were a little skeptical, but they're now like, oh, we're so happy we started doing this. And so that would be my suggestion.
I would just add, just because we don't ask doesn't mean that someone's not experiencing it. And so specifically thinking about our YETI study with the CHETI measure, it's complicated. We have lots of rhymes. But, that can impact adherence and what someone is doing that they may or may not feel comfortable sharing. And we may think that the barrier to whether it's ETI adherence or coming to clinic or, sharing with their caregiver how they're feeling is something that's completely different. And until we ask and we understand exactly what the barrier is, it's hard for us to have an effective intervention or an effective conversation or to leverage the relationship that we have as the care team member to be able to work with the individual and help address it. So I think I understand that it can feel, especially because we don't have as much of this data yet, that it's hard to justify or it can be uncomfortable to ask, but that doesn't mean that people aren't experiencing it just because we're not asking. And then I think the data we have from the CHETI study, is really something I've thought a lot about, in that we know the majority of people, as if you remember those graphs that were confusing, a lot of the middle part of those graphs were people who didn't report changes. And so that's reassuring. That's really helpful and important. And we can't turn away from the yellow and the dark blue. And so I think it's important to know that it doesn't mean that it's everybody, but we have to acknowledge that people are experiencing that.
Yeah, I think that's something that we're all feeling, sort of how to balance the conversation about side effects with benefit.
Hiya. First of all, I'm just wrapping up a PhD and spent all day referencing this group of people, so I feel like I'm meeting celebrities. I just wondered if you have any advice on, obviously we're in an era of uncertainty, and how we manage that in conversations with families in a way that's honest, but obviously they're looking to us for the answers, so that we keep their confidence but own some of that. So just, I guess, any advice and tips in communication around uncertainty. Thank you.
My experience is when you start out with, here's what we do know, and here are what some of the hypotheses are, and here's some of what may be going on, and you share what you know and don't know, then people trust you, right? You're saying, this is what I know, this is what I don't know, and this is what we can do. And then people feel hopeful. And thinking again about how do we have these conversations, this is a point I think we've been making over and over, but mental health screening isn't just meant to be a checkbox like, okay, yeah, in the registry I can check I did that. It's meant to be a conversation starter. So even if someone's symptoms are low, we heard about, right, the person who put all zeros on the modulator side effect checklist because they don't want anything to happen. So regardless of how someone's scoring, let's make that a time for a conversation. What's going well in your life, what's not going well, right? And when you build that relationship, even if it's brief, it doesn't have to be that you're spending an hour, having that conversation if things are going well, then you're setting the stage that when these more difficult conversations are needed, they're more likely to happen.
Just quickly, we've used the CF Foundation has a program called PEP, and if you aren't aware of it, you should find it and learn about it. They also have trainings where they train care team members and care centers, and we have used at our center, we have used PEP and the skills and the framework and the tools as a way of having and starting these conversations around ETI, and asking, an example would be asking people what they, a caregiver, for example, in our pediatric center, what worries them the most about it? What have they heard? What feels hard to talk about when you're here in clinic? I have some thoughts about things that I've heard or what I know and what I don't know, but what's on your mind? And so I think using that PEP framework that we know really fosters and cultivates and improves relationships where there's trust and only helps, I think, both care team members and clinicians and families be able to, and people with CF be able to talk about it. Okay, PEP stands for Partnership Enhancement Program, which is essentially a sort of a communication skills training where care centers are taught, team members are taught to collaboratively establish goals and priorities and work with individuals with CF and their families around their care and what's important to them and how we can partner with them.
One other thing from the adult side, and this just reminded me because we have one of our nurse practitioners in here, is to really partner with your team because your patients may have a really unique bond with some of their providers, nurses. If they make it okay to open up the conversation, they don't necessarily have to have the answers, but they can do a warm handoff to your social worker, to your psychologist to continue that conversation. So some of it starts with you talking with your team and normalizing, hey, some of this stuff might come up. We don't have all the answers, but if it does come up, let them know that I'm happy to pop in, or I'm happy to send our social worker in, or whatever it might be. So not just focusing on what we can do, but also focusing on how you can connect with your team to make this part of the dynamic of how you talk about this with people.
I know we're at time. I want to thank the presenters again with a round of applause and the audience for being so terrific.